Yeah, I think hopefully we'll have time to get through them, no problem, I'm hoping. Let me just set a timer here we'll take a break. 50, 45 minutes. I'm not sure how long it'll take me to do the PowerPoint. Okay. All right, so radiographic techniques. So these chapters were pretty much on what we'll be doing in the upcoming labs, which are the paralleling technique, which is essentially what you do with the XEP. The XEP is a device for the paralleling technique. And it's a little bit, I mean, depending on the person's mouth, it can sometimes not be perfect. We'll talk about the reason why that is, but essentially that's what you're doing with the XEP is it's giving you a little ready-made setup for the parallel. Then we'll also talk about bisecting the technique. I'm trying to advance the slide here. We'll talk, I think I already talked about that. Oh, I did just want to remind you guys, when you're in lab, you remember you'll X out of Axiom and then you'll go down into the main screen and there's that little orange log out button. You double click that kind of closes you out and logs you out. But the other thing, and I don't know if they want this on top of it, but you might as well do it just to be safe, is to go down to the lower right and just restart, because they are always having problems with films not wanting to come up because somebody else is logged in. And the best way to just get around that is to just restart the whole thing. So once you're all done with your session in lab, just log out and then restart it. And that would be, hopefully it'll clear the problem for the next person. Yeah.
So on the exam, did we study also from like the first PowerPoint?
Yes. Yeah, so from the first week, there was a couple PowerPoints.
Like 24 to the end.
24. Oh, that was for the first quiz. So for the exam, though, you'll want to do it all. Just do it all. Do it all. Yeah, so from the very first, so every PowerPoint basically that we've covered, you want to review those through to today's slides. Yep. So every single PowerPoint that we've looked at plus today's PowerPoint. Okay. These are the objectives. This is kind of the outline. So we're talking about intraoral projections, the different types, which different kind of radiographs, the techniques, which is the paralleling and the bisecting, and then we'll talk some more about criteria, which you guys are already doing amazingly on. You're already a head start there. And then the next PowerPoint that I'll pull up is on mounting. So that's what we'll talk about today. So we're kind of getting away from, it's like a little break in the real sciencey kind of stuff, electrons and circuits and stuff like that. And it's just more technique. And then after the exam, the next unit is the radiation biology. So it goes back into like kind of cellular stuff and the effects of radiation on the cells. But that's not going to be included in the exam because that's just too much of that kind of content in one exam. So there's different kinds of sizes of films. You can see them there on the picture. There's real small ones that are usually used for children. In digital x-rays, almost always, and the dental assistants here will know that very seldom do you switch out your digital sensor size. This is really harkens back more to traditional x-rays. But some places will have a child size sensor and an adult size sensor, and that's not uncommon. But the digital sensors, for those of you who haven't used these before, and you might have noticed since everybody's been in lab at least one time so far, that it's not huge. It has nice rounded corners. So there's a lot of things about the digital sensor that make it easier to use on almost everybody. But for small kids, they do still have a smaller child size. And we actually have one. We have a pedo sensor. We might have two now. We might have bought a second one. But we do have a pedo sensor, and we use that when we do Give Kids a Smile, which is like a volunteer thing that we do every year in February. Yeah.
About answer, but such a small space.
Yeah, You could, we don't really have it out and available because we've just always used the size 2. But in private practice, that might be another reason why you might use it if somebody's mouth is really narrow or small. So you can see there, and size 1, adult anterior, size 2 is your sort of traditional, size 3 is a little longer. And then size 4 is for predominantly for occlusal images. So we don't have any of those. We have traditional film that we can look at in lab and you can kind of see, and we could use it on Dexter, but we don't have any way to develop it because we don't have a developer for traditional films.
Yeah. 0, 2, 1 thing, is that an error? Or what are those numbers for? That are going across the number 4 center?
Oh, I think that's an error. Yeah, I didn't even notice that. I don't know what that came from. Yeah, this you guys, this 0, 2, 1. If you have a fancy thing of bobber, you can get rid of those. That's, I think, just an error. I'm not sure why those popped up there. But this is important to know. This is content that could be on a quiz or an exam, knowing what the standard film size is, what might be a child size, and what might be used for an occlusal. So this is information you might be tested on. So as far as intraoral projections, there are these different types here, and we've already talked about this some. So this is kind of review, but we have the periapical films. Yeah.
Sorry, you don't have to know what
No, just generalized size 0, 1, 2. Yeah, yes. So periapical is a film that shows you the entire tooth from the top of the tooth down to the root, the apice. And so you want to see the whole crown and at least 2 millimeters of bone around the apice. And so there's several different periapical films in the anterior and the posterior. And then bite wings, we have the horizontal bite wings, which will show a little bit more teeth from front to back, but not as much bone from top to bottom, maxillary mandibular. And then we have the vertical, and why would we take a vertical over a horizontal? Patients with periodontal disease or bone loss. Yep. So like typically if somebody comes in and you don't know anything about that patient, you wouldn't be like, come on, let's go back and take some vertical bite wings. You wouldn't do that until you've done assessments and you realize kind of what's going on in their mouth. And that being said, what actually tends to happen a lot of times is students will say, come on, let's go back and take your horizontal bite wings, without looking back and seeing that this is an existing patient in our clinic and they've had vertical bite wings before. And that's actually what you want to be taking is vertical bite wings. And so usually you're supposed to look back in their chart, know that, and tell your instructors that that's what you're doing. They actually want to know. So this is jumping way ahead to patient care, but you know, it's fun to have those things in your brain floating around. And then when you hear it again, you're like, oh yeah, I heard that one place. Occlusal films, a lot of times we take occlusal films to just get a different perspective of the jaw and the teeth placement. You can see if there's a supernumerary tooth or if there's something impacted, you know, like an impacted canine or something. You can also see if there are salivary gland stones or something in the glands, because this is the mandible here, and all of this soft tissue is this area just, you know, all through here where you have your different salivary glands. And it's not uncommon for stones and things. So somebody might have swollen, sore area, and you're like, ah, geez, I don't know what this is. And then you take an occlusal film and you see all this white calcified pebbly looking stuff, or just one if it's a big stone. And so it's used to diagnose things like that. Yeah, you could. And a lot of times, like when I first started, I would just take 2 bite wings, and then I would take a maxillary occlusal film and a mandibular occlusal film, and just come in at these sharp angles. So very oftentimes you'd take it on kids that way too.
Yeah. So for the occlusal start right here, the last one is an X-ray.
Yeah, that's how it's supposed to look. Yeah. Yeah. And there's like 4 different occlusal films that we'll talk about when we get to that point, and that's later in the semester. And we actually just are going to cover it in lab. We're not going to do an in-class lecture, I don't believe. And so there's a couple different like lateral, and then the ones that just either kind of come straight up or straight down. So we'll talk about those more in depth when we cover that unit. Okay, so the 2 different techniques, we have bisecting the angle and we have the paralleling. And one of them, bisecting tends, and this I'll probably end up repeating myself because I'm sure I have it somewhere in a slide. But the bisecting the angle is where you have to figure out the angulation of your BID relevant to the teeth that you're taking. So you're going to use, you may use an XEP. You may end up using an XEP, but we think about it a little bit more in terms of the snap array, which you guys don't have one of those in your kits. We have them in the clinic. And it might, a lot of times we do bisecting the angle when somebody is they're not tolerating the XEP for whatever reason. There's something going on in their mouth. We just can't access the angle very good. Their mouth is small, or maybe they have big tori or torus or something. And so then we use a snap array. And then we have to figure out the angle. And so we'll talk about how we get that. There is more distortion that happens. You can see, can't you guys see this looks more distorted than this? Does that kind of catch your eye? They look shorter. You can see the palatal root kind of flaring out. You can see what seems like it might even be the occlusal surface, whereas this, it's nice and straight on, and the bone looks accurate. The bone doesn't look distorted. And this is paralleling technique, and that's done with your XEPs, like I said. So the first one we'll talk about is the paralleling technique. So parallel, and just this is good because it kind of, when you hear these terms, when you're using the Q-tip for opening the contacts, you know, we say we want the cotton swab or the Q-tip to be parallel with the BID, and then we transfer it from the BID to the metal arm of the XEP. We always want them to be parallel. So obviously this is like what we mean. We want like 2 railroad tracks, they never cross. So we want the sensor, or over here, we want the sensor, the digital sensor, to be parallel with the long axis of the tooth. And the long axis of the tooth is just sort of an imaginary line that basically cuts the tooth in half, generally equally in half. I mean, it's a bit of a guesstimation, but when you think about the tooth, you know, and the direction that it is in the head, you're generally continuing on that line, and you want the sensor to be parallel with that imaginary line. So film or the sensor is placed parallel to the long axis of the tooth. Vertical angulation with the central ray, or your primary beam that's coming out of the BID, is directed perpendicular. So a 90-degree angle is perpendicular to the film and the long axis of the tooth, because those 2 things are parallel. So then we have the BID, or the primary beam, coming in at a right angle or perpendicular to those lines. So you can see here, we have the long axis of the tooth here. We have the film sensor here. They've bitten down on this bite block. And then we have the ring would be right about here, directing your BID and your primary beam to come in perpendicular. So you got this right angle right here. And the same, if we continue it onto the sensor, it's perpendicular or right angle. Your horizontal angulation is just going to be through the contacts. So that'll vary, whatever area of the mouth you're in. That's going to vary. So this is showing it accurately, and this is showing it inaccurately. So this would be not parallel. And you can see how this angle is more obtuse. It's a bigger, it's a wider angle. It's not 90 degrees, it's more than 90 degrees. So we're going to get some distortion there. So that's going to result in vertical angulation error or distortion of the tooth. Here's just some more images of it. We have the tooth here. We have this, this is an old traditional style film. We have the tooth and the film parallel. And then it's showing how if they're parallel and you have the primary beam coming in at a 90-degree or it's perpendicular to those, you can see that what's happening is when that image is projected, it's going to project this roughly the same size of the tooth onto the film. So you're not going to get a blurry sort of distorted tooth or a tooth that's like smaller and distorted. It's going to be roughly the same size if you're perpendicular to those two parallel lines. So that's what that's showing there. And it's kind of how it can vary depending on if you're in the anterior region. See, it might be a little tilted altogether because your anterior teeth don't go straight down. They kind of flare out a little bit. So then this might be tilted a little bit, or when it's in the posterior, it will be a little bit more straight up and down. So it's just showing some variation in how you'd angle the sensor. With bisecting the technique, we are still going for a right angle with the primary beam coming in, but now instead of it being at a right angle with either the sensor or the long axis of the tooth, we're going for an imaginary line that we have determined in our brains. And so this is a little bit trickier. So first we need to understand what it means by the bisector. And what it means by the bisector is when we have two angles and we cut that in half, then that imaginary line that cuts those two angles perfectly in half is called our bisector. And so what we're going to make those two angles from is the film sensor. That'll be one half of our angle. And the long axis of the tooth, I need like sticks. I'll use my arms though, if my elbows can reach. But you want one side is the sensor, and then the other side is the long axis of the tooth, and they come to a point. So that's your angle, and then your bisector is halfway in between those, and it's an imaginary line. It's nothing that you can really see. It's just, and it's going to be different on everybody because everybody's teeth are slightly in their mouth a little bit different. But those are the two things. And then you want your central ray. So here we have the film. That's one angle, that little green line that just popped up. Then we have the long axis of our tooth. That's the next angle. So now we have the V. And now halfway in between is, oh, I did them too fast. But halfway in between is our bisector. And then we want our central ray of our BED to be at a 90 degrees angle to the bisector. And this is the technique that we use with the snap array. So when we do this, what we do is, if I'm remembering how we run the lab, I'm pretty sure that we'll do anteriors one week and posteriors another, and you'll go into the operatory and you'll have your XCP, and then you'll have a snap array, and we'll say, take several with the XCP and then take several with the snap array, and Teresa or myself demonstrate it. Because Dexter's not a good patient to do a bisecting the angle on because he can't bite great and he has no arms to help you. And so we have to use rubber bands to like get the snap array to stay. And there's kind of tricks to it. It's kind of a little bit crazy, but it works out. I mean, you can see it demonstrated. It's just a little bit funny. I think the anterior is way easier to see on Dexter than the posterior. The posterior is harder. So the fundamentals of bisecting the technique is the patient's head position needs to be, their occlusal plane needs to be parallel to the floor. So you want to make sure that you want everything that you can get just so that you don't have these things changing the angle. So you want your patient's occlusal plane to be parallel to the floor so that their head is nice and level. You want the film sensor placed on the edge against the incisal edge of the tooth. So the sensor is the bottom part where the patient bites is gonna come down to the incisal edge. And then as the sensor goes up into the palate or down into the floor of the mouth, it's gonna go away from the tooth. So they bite down with their incisal edge close to the edge of the sensor when they bite, so they don't bite on, let's say you're using your XCP, if you have them bite away from the sensor, you're essentially doing the paralleling technique. So you want their incisal edge to be close to the sensor. So film sensor placed on an angle against the incisal edge of the teeth. Vertical angulation with central ray is perpendicular to the imaginary bisector. And we do have some numbers some cheat sheet numbers here in a minute, and you don't have to memorize these. But I would recommend you print them out or bring them with you to lab. I think I usually bring them too. But you'll want to look at them when you're in lab, but you don't have to memorize these for a quiz or exam. The horizontal angulation is through the contacts. So again, always just trying to open up those contacts. I'll show you when I get to that slide, you can highlight it so that you'll know exactly what I think it's just a few slides. It's like maybe the next slide or something. I'll show you. So film placement, center film, or center the film or the sensor behind the region to be radiographed, which is that's a little bit deceiving because its placement can be a little different depending on if you're on the premolars or not. But it works very well if I'm describing a canine. So if you're describing a canine shot that you're taking with a bisecting technique, you want to center your canine. If you're taking an anterior, you want to center your central incisors, your first two teeth. You want to center that on the film. So that's essentially what it's saying. Vertical angulation is more or less standardized. So once you get it all placed, these numbers that come up here, like on the next slide or so, they're going to help you know. And then if you take the film and there's too much distortion or you may have to lessen or increase your vertical angulation, but these are pretty standardized angles, and they usually work out pretty well actually. And then horizontal angulation through the contacts. So here they are for the bisecting. So when you're taking a maxillary central incisor and you have the film placed, and you can place your film in Dexter, and you can look at where Dexter's teeth are and where your film is, because we don't really have them closed down very much because we just rubber band it to kind of hold it. So you can see, okay, here's my sensor, here is Dexter's teeth, and then just like eyeball it. I mean, literally that's all. I mean, I can't explain it any better than that. You see those two angles and just imagine where the halfway point is. Make a image in your mind of that line, and then do what this says. So like you're going to bring your direction 40 to 50 degrees pointed down, or it's positive when the BID is pointing down. So put it there, but then like look at it and test it and be like, okay, my bisector is here. And you can say, oh, that does actually look like it would be hitting it perpendicular, or no, actually, I feel like I have to tilt it slightly one way or the other. And this will be easier, obviously, once you're in lab doing it, but it is actually, especially when you're in the anterior, you actually can kind of visualize it. But these are the numbers that you're just going to kind of automatically start with, and you might shift it slightly, 40 to 50 downward, 45, 55, premolars 30 to 40, molars 20. So it gets flatter and flatter as you get posterior. And these are the numbers you don't have to memorize. So you don't have to memorize these. The next one is from the mandible. I'm like, I couldn't decide if I wanted to say mandibular or mandible, like which makes more sense in this sentence. But these are for the mandibular images, and you can see that now where the BID is pointing upwards, and it's at a little bit less of a dramatic angle. And yeah, so you do not have to memorize those, but those you will want them handy in lab for sure. So this image here is just, oh, this is showing you that, so did everybody take a second when you were in lab to notice where this degree thing is located? Yeah, a lot of you did. If you didn't, remember for bite wings, it's about positive 10 degrees. So it's at a slight angle downward. So that would, so when it's at 0, this is 10, 20, 30. So it'd be right about here for bite wings. That's the standard for bite wings. And so then if you're doing maxillary shots with the bisecting, you'll be up here. If you're doing mandibular shots, you'll be below the 0 here. And it's right there on the tube head. You can just look at it and move it around. This is just some images for the bisecting for what it might look like in the anterior and in the posterior. Now the palatal root, and this might be somewhere in the slides to come. But just because this is a pretty good image, do you see how this palatal root is larger looking and longer? So the palatal root almost always, our maxillary molars have 3 roots, and the palatal is the mesial and distal roots are buccally oriented, and the palatal root is lingually oriented. And so it's farther away from the source of radiation. So that means that by the time the beam gets to that palatal root, it's more dispersed than when it captures the first 2 roots. So the palatal root always looks bigger, a little bigger and longer. So there's always distortion, and you may see more or less depending on the angulation, the patient's mouth, like there's lots of variables, but that's common. And if you're doing bisecting the angle, you're likely to see more distortion just in general in that area. So which one of these, 1, 2, or 3, is the correct bisector? Or which one is the bisector? So 3, yep. 3 is the correct answer, because it cuts it perfectly in half. So we have, and so it doesn't really matter so much what the angle is. Like you could have a wider angle or a narrower angle, but the bisector will always cut it in half. It'll always cut it in half equally, which is cutting it in half, right? Okay. So with paralleling, paralleling is the preferred method because there's less distortion. So there's advantages though, and there are disadvantages. And that's why we have another system, because there are some disadvantages to the paralleling technique. Advantages for the paralleling technique is that it's less distorted. Like I said, typically the images come out more accurate. The tooth and the film are easy to see and direct the X-ray beam where you want it. It's easy to get those 2 things lined up, especially with the XEP, and then you're just automatically lined up to be perpendicular with the ring and the direction of the beam. So everything's sort of just set up made that way. Although there are exceptions to that rule as well. You can end up getting distortion because you can't get it parallel with the tooth. And then there's lots of different holders that are set up to just automatically do paralleling, like your XCP system. Disadvantaging is that placement can be difficult in patients. So in order to get it parallel, you may have to get further away from the tooth. Like the closer the sensor and the tooth are, and we talk about this in another unit as when it comes to like the clarity of the images, but the closer that the tooth and your film are, the clearer your image. So if you have to move your sensor, say you have to move your sensor more to the midline because the vault of the palate is higher, you have more room once you get farther away. Or, if you're on the mandible, say there's big tori or something, and you have to move away from the tooth, you're going to get a little bit more distortion. So, but sometimes you just simply have to do that because the patient's mouth is small or, a number of different reasons. So there is some difficulty in placement to get the accurate image at times. Small mouth, low palatal vault, presence of tori, gagging, those are the main ones. It may cause the patient discomfort. So we have to place it, when we tell our patient to open and we go in to place the film, very commonly a patient will say, no, it doesn't fit. And you're just gonna happen. And so then you go in again. And a lot of times you just have to work with them a little bit. Like it literally can fit many, many times. And you guys who've placed images, this. Sometimes it's just a trick on, let's have you keep your tongue under it. Let's put a little squishy corners on it so it's a little bit more comfortable. Or saying, I know that this is uncomfortable, but if you relax your tongue or you just let me place it, it might you kind of give them a little head start. Like you may feel this a little bit, but if you can just hold it for a few seconds, I'm running in and out of the room real quick. You talk them through it. And you guys who've had experience, you know that talking your patient through it is sometimes 90% of it. And if they know that you understand what they're going through and you're not just saying, just tough, live with it, you kind of talk them through it, they'll tolerate it a little bit better. Gagging can be one of the hardest ones because sometimes people just plain can't control that very good. So that can be a harder one. Bisecting the angle, advantages and disadvantages, the film placement can be easier because you can literally like say you put you want the XCP in there and you want to get it back posterior enough, but the patient's gagging or they won't let you. Very oftentimes you can sneak in there with the snap array and you can get it in there and without pushing it back too far, and you can angle it kind of in a different way and you can get the image and it won't trigger their gag reflex. Or if they have a bony, something in their mouth that's obstructing the placement of the sensor. So a lot of times we can get away with it, but we end up getting more distortion when we do that. So it's kind of a trade-off. The disadvantage, more dimensional distortion, estimating location of imagery bisector may be difficult, especially in the posterior. So it can be hard to be like, okay, where's my bisector? Like I know my sensor is probably like this and their tooth, I guess, is like that. And so then you just kind of guesstimate. But really, if you use those degrees from that earlier slide, a lot of times you can at least get pretty close. Okay, so now we're looking at the different films that are in FMX and kind of talking about the criteria for each one. So the first one here are the central incisor films, and it shows in the images, it's kind of showing where generally you'd want it placed. So here's your film, and it's generally right behind your 8 and 9 or 24, 25. Depending on if you're up or down, maxillomandibular. And then here it's kind of showing the side, if you were to cut it in half and get a cross section of it, you have, and you see how there's a fair amount of distance between the tooth and the film. Whereas if this was a bisecting, the film would be coming off like this. So there's quite a bit of distance between these two. So you do end up getting a little bit of a bigger kind of image. And then we have our central ray coming down through here, but you can see how that'll come down perfectly perpendicular. And sometimes we have, this is showing a little bit of a cotton roll. Sometimes we'll do that if people have trouble biting or if they're missing a tooth. There's different reasons that someone might use a cotton roll. This should be roughly what is captured on the film. We should see in between 8 and 9, and then we should see the contacts between the laterals and the centrals. Now, this is a beautiful one, and all the contacts are roughly open, but that doesn't always happen. Sometimes people could have overlap in their laterals, and you can see obviously between their central incisors, but between their laterals and central, you might get a little overlap. If it's less than a third, it's okay. But if it's really overlapped, you may have to end up taking 2 separate films. Also, sometimes you end up just randomly opening those contacts in a canine film, which is all, just because you happen to get that tooth in there. So sometimes you get lucky. The other thing too, and this is sort of me maybe talking a little bit out of turn, so always leave it up to your instructor and the doctor. But a lot of times you can actually look at somebody's anterior teeth, and through something called transillumination, which you guys will cover at some point, you can kind of use lighting and see if you can see any kind of decay. A lot of times the doctor still wants an x-ray, because if something's like incipient, like it's just barely starting, they really will want to see it on an x-ray. But if you have struggle bust through an FMX and you're running behind and it's just a hair over a third, don't hesitate to say, is this going to be okay? Your instructor might say, no, you got to retake it. It kind of just depends on the patient and the circumstances. But I have seen several times when the lateral and the central aren't always lined up this nicely where every contact is open. But that's the goal, is to have all those contacts open. The key contact is between the centrals. The contact should be open mesial and distal of the central incisors. So basically all contacts in the film. You need at least 2 millimeters of bone at the apices of all these roots. So the laterals and the central. And of course, this is easy to get far more than 2 millimeters. You'll get far more than 2 millimeters. Crowns of your central incisors as well. If you just barely cut off the incisal edge, it's fine, because again, they can see that area with their eyeballs. That area really is fine. If you cut off like a good chunk of it, I think that the criteria says, like, I thought it said more than half, but that seems like an awful lot. They may have you retake it, but it is an area that you can actually visually look at. You can look at the incisal edge and see if something's going on. So you don't always have to retake that. The next one is the canine. So this is basically the same whether you're on the maxilla or the mandibular. You want to center the film over the canine. So this one isn't really perfectly centered in this drawing, but you want to center the canine. And so again, when you're taking your film, you're looking for it to be pretty centered. Sometimes the root will kind of kick off one way or the other, but in general, you want it centered. Very oftentimes you don't have to retake if it's not perfectly centered unless something's missing. And then another thing that a lot of people will ask is if they didn't get the first premolar's apice, they'll say, oh, I got it in my canine. Can I just use the one in my canine shot? A lot of times it's very distorted. There are sometimes, very rarely, when it'll actually turn out good and it's like, oh yeah, I guess you could use that one, but that's not a given. Just because you have the apice doesn't mean that it's not too distorted. The doctor might want it in a different plane or with less distortion, so you might have to retake the premolar instead of using the canine. Key contact to open the contact is between the canine and the lateral. So you want to open the mesial of the canine and the distal of the lateral. Contacts to open the mesial, basically everything mesial of the canine. So we know that the distal of the canine and distal is going to be just absolutely a given. 99% of the time they'll be closed. And so that's your one exception for horizontal angulation. That's the one film where you don't have to mark horizontal angulation error if it's distal to the canine. And that's the only film that we do that on, because we're on a corner, and unless somebody has a very broad, wide arch, you're not going to open those contacts very likely. So that's the only exception. Apex and crowns of the teeth visible, including 2 millimeters of bone surrounding. Distal contact of canine will almost always be closed. Here's just another image of a mandibular canine. So you see it's kind of centered there. For the premolars, position the film so that at least the distal of the canine is seen on the film. We want to see the enamel and into the dentin. So if you're just into the enamel and you're like, oh, is that far enough? No, you want to see into the dentin. The key contact is between the first and the second maxillary molar. So that's going to be your key contact. And then for bite wings, oh, that's confusing. Sorry. For bite wings, it's maxillary. If you're on the mandibular, if you're on the mandible and you're taking a mandibular PA, it's obviously not the maxillary. So you guys might want to make a note of that. And that's a typo. So this is for, so the key contact for the maxillary premolars is maxillary PAs and bite wings. But mandibular PAs, it's going to be between the mandibular premolars. Yeah, just cross out. Yeah, because we're talking about PAs. So, and you can make, yeah. And then the slide, when we were talking about bite wings, it should say maxillary, I believe, on the slide for the bite wings. Contacts to open mesial and distal of both the premolars. So you want to here, here, and here. So you want to see all these areas open. This one is okay if it's closed between the molars, but sometimes you get it open, and then that's great if you happen to close it when you were taking your molar film. So sometimes it works out that way. apex and crowns of teeth, and 2 millimeters of surrounding bone. And then again, these images are just kind of showing rough placement and then how it looks in a cross section. And that's just another example of it there. And then for the molar, the position the film so that the second molar is centered on the film, or the anterior edge of the film is close to the mesial of the first molar. That's different from the book. I still say just focus on the second molar. Your key contact, again, this is another area you could cross out maxillary. Obviously, if you're taking a mandibular shot, your key contact is between your mandibular molars, not your maxillary molars. So you can cross out maxillary there. So it's between your first and second molar, whether or not you're on the top or the bottom. Contacts open, you want to open the mesial and distal of all the molars. And then again, 2 millimeters of bone surrounding it, apex and crown of all teeth visible. It is not necessary to see the mesial of the first molar because very often you'll see that in the premolar shot. So if you don't have it in the molar shot, that's not a criteria problem. As long as you've centered the second molar, it's fine. And you'll get if you do get the mesial of it, great. If not, likely you have it in the premolar shot. And here is an example of it. They don't center the second molar, so it's not, I should probably put in one of our images. In the textbook, they don't have it as one of their examples. But in our images, we would want the second molar centered. It's not necessary to see the mesial. Okay, we already have that comment from before. So here you have the mesial of the first molar, which is great, but if you didn't have it, if you cut it off because you're centering the second molar, then you likely have it in the premolar shot. Okay, so I don't know if this is actually, I think my activities or my practice is at the end. So just skip over that slide. And we're almost, actually, I have like 3 more minutes and I was going to have us do a break. So let's just do a little stretch break, like 5-minute bathroom break, and then come back and we'll finish this slide deck. We want to evaluate every single film for error and we critique to perfection. But remember, that's like one category. And then we have retake as our other category. And those two can be very different. So sometimes it ends up a film that you've critiqued also obviously because of those errors need to be retaken, but sometimes you critique it and it has errors, but you don't have to retake it because it's still diagnostic. It still gives you the information you want. So what constitutes a retake? The goal is to take as few films as possible to get all the required diagnostic information. So we're not trying to, I mean, and some instructors will give you a really hard time. If you ended up getting all the diagnostic criteria, but it's an ugly set of films, you'll probably hear about it. So yes, we want it to look as nice. We don't want very many cone cuts. We don't want all the films to be wonky. You know, we want it to, you know, don't want a lot of distortion. So we want to minimize all that. But obviously, as you're learning, some of that stuff's going to happen. But you can end up with a set of films that doesn't look the prettiest, but it still has all the diagnostic information. And we don't want to just take films on patients just, you know, cause we want to stop at a certain point once we get all that diagnostic information that we need. So it don't like to advance on me sometimes. Okay, so errors does not necessarily mean retake, and I think we've kind of stated that pretty plainly. So the errors review horizontal angulation, basically opening, or if the contacts are either open or closed, you can you will mark an error for horizontal angulation no matter how much there is, but you will only retake it if it's more than 1/3 into the enamel. And the way I eyeball that is like I kind of look at what's half of the enamel, and then I kind of go, is that sort of significantly more or less? Like if it's a half, it's a retake. If it's like significantly less than a half, like, and we're talking less than millimeters. I mean, I don't even know exact measurements, but it's pretty small, obviously. And there are measuring devices in the digital x-rays. You actually can pull up little measuring devices, but that can be tricky, and then you don't want to end up screwing up your film somehow. But anyways, you just eyeball it. And if it looks like it's roughly, a little bit less than half, then you're probably good. If it's just a sliver, you're good. But if it looks like it's, half or obviously more, then you have to retake it. Vertical angulation, mostly just for the PAs. Like we said, in bite wings, it's not very common to get vertical angulation error when you're taking a bite wing, but you will have it foreshortening and elongation and foreshortening for the PAs. Placement and beam centering. So we're gone. Yeah.
If there is a vertical angulation error with like a right wing and the crowns are kind of overlapping each other, is it still a third?
That you would probably, because that happens so infrequently, that hasn't come up where we've had to address it in clinic. But I would say if it severely has distorted the image, or if it's interfered with that interproximal space where the teeth come in contact, and where you're really looking for decay in an area you can't see otherwise, then retake it. But if it's just, if it's gone into the enamel, I probably would leave it up to the dentist's discretion. Like I'd have the dentist take a quick peek at it, because you can always do that. You can flag your instructor and say, I don't know if this needs to be retaken or not, because it's in kind of a unique area and we don't usually have to mess with that. Closed contacts overlapping. And so what's the error? If you have overlapped, what have you not done? You haven't gotten the beam through the teeth, and what did you probably not use that you should have? The cotton swab. And the one thing when you guys get into patient care, especially your senior year, because I don't know exactly what happens in the spring when you see patients in the spring, but there's sometimes like a little bit of loss of this information in the spring. And then when you get into senior, nobody goes for a Q-tip, no, cotton swab. Contacts are closed all over the place. And so so don't forget, until you've mastered that, always use your cotton swab, because it might seem tedious and you might not have done it in private practice, but just get in the habit of doing it here, because your instructor will say, why are these closed? And you'll be like, I don't know. And they'll say, did you use the cotton swab? And so you'll hear it. So just kind of remember it through all of patient care. Was there a question over here? No. Okay. So how do you fix it? I kind of answered that. How do you fix it? Use the cotton swab. Use the cotton swab. Use the cotton swab. You will get to a point where you can eyeball the angle. And some of you may be there already. You can look at two teeth and you can look down from an occlusal view, or, it's harder for a maxillary because you can't really vision, but you still get used to it. But you can look at it and go, all right, I kind of, that imaginary line, just like with the bisector, you can be like, all right, I imagine that this is the angle I need to be to open the contact. And it really becomes that once you're really accustomed to taking films. But in the beginning, that's not so common. If your overlap crosses the DEJ, the dento-enamel junction, and this clearly does, and it cannot be seen in any other film, it requires a retake. But if it can be seen in another film, you don't have to retake that film. So if you have that contact somewhere, then you're good. If your overlap does not cross the EJ, it is still an error, but does not require a retake. So this, but not this for horizontal angulation error. Foreshortening. So what is the error with foreshortening? Yep. So it's excessive. And I like to think about it. This one is a little, you can just memorize if your BID is like really vertically steep. If it's really steep, you're gonna foreshorten it. And you can kind of think about, I have to think about it in my head to make sure I'm saying this right. But you can kind of think about as the sun, if you have a tree and the sun is rising, when the sun is low in the, No, that does work. Okay. I always am like, does this work? If the sun is low on the horizon, you're going to have a long tree shadow, or you're going to be a long shadow if the sun is low. But as the sun goes up higher and higher in the sky, the shadow is going to become shorter and shorter. And if it's like right on top of it, there is no shadow around you, and you're just like it's around you somehow. Does that help any? I don't know. It helps me if I think I'm thinking about it correctly. So foreshortening, the error is that you're too steep, and so you're smushing down. And it's also really neat to draw this out. You can draw this out because if you draw the long axis of the tooth and you draw the sensor, and then you make very steep parallel lines. If you measure the length from here to here, it will be shorter than the length from here to here. And you can draw that out, like use a ruler, and it just will be shorter. And so you're squishing down the image of the tooth for foreshortening. And this is did I put these in or did the book put these in? I don't know. But so this kind of shows in red. So this length is shorter than this length because your angle is too steep. And you can see this is the bisector here, this dotted line. This is the bisector, and the central ray is not perpendicular. So that's where more distortion came. So if they were doing a bisecting technique, they needed to lower the angle, tilt this back a little bit to flatten out that angulation a little bit to get it to be perpendicular with the bisector, which is this dotted line. And there's some notes here on I don't know if you can see it in the PowerPoint, but if the PID is too steep, then the image is short. And so they kind of have like some memorizing steep equals short. Yeah. Cementum is on the root, and dentin. So dentin is on the crown and the root, but cementum is only on the root. Yeah. So here we have another image for this one. Actually is out of place. This one should go down. I feel like this should have been moved down a couple slides. But this is also showing the same thing, but with elongation. So if you are too flat, then you can see that the length of the tooth image is longer than the actual real image of the tooth. And so it's too flat. And again, this is not a 90-degree angle with the bisector. This is greater than 90 degrees. You can see it's more open there. So this next one, so this should have come before that last slide. But so elongation, so what is the error? So the error is that your BID is too flat, and you can see that here in this picture. It's coming in too flat, so it needs to be either brought up a little bit if you're on the maxilla, or brought down a little bit if you're on the mandible, and steepen that angulation just a little bit. And this is pretty common with, and sometimes you have to do it on purpose. Like sometimes you just have to distort something to get the image. And that does happen sometimes. And a lot of times your instructor will be with you because you'll have tried the other way and it didn't work. And they're like, we're just going to do this to make it work. And so sometimes you do have to just distort the image sometimes. Yes, some people have really long roots, and that can be, and it's like no matter what you do, you feel like you cannot get that tooth on the sensor. And so then you're like purposefully trying to actually foreshorten it a little bit. You come in steeper. That's a perfect example. So here is the vertical angulation error for the bite wings. Again, not very common, but it can happen. And that's usually if you're doing it with the tabs, or you don't have the ring and you come in at a different angle than just the 10, or it could perhaps be because of their bite, their occlusion for some reason, but not as common for that. So tips to determine vertical angulation errors: look for extreme cusp separation. Check the same tooth on the opposite side of the mouth. did the roots seem long everywhere, or is it just that one image? Maxillary molar projection, the lingual root will appear longer, the buccal roots will appear smaller. That's just because of the distance. The palatal root is oftentimes flared out more lingually, or palatally, whatever. And then the mesial and distal roots are more buccal, and they're closer to the actual the beam that's being emitted from the target. So they're just closer to that primary beam than the palatal root is. And then mandibular anterior projection will often see the border of the mandible in the film. So a lot of times you'll get different anatomy, like you'll actually see the border of the mandible. And so you might get some like just black area, and where you see that the bone has just ended the jawline. Okay, so some technique errors. So here we can see that there's been a fair amount of the incisal edge cut off here. Here you can see that we have cut off the apice. So a very common, what do you think in this one, for instance, what do you think went wrong in this molar shot? Yeah, that's almost always they're not biting down hard enough. And so a lot of times when we're first getting used to taking pictures in somebody's mouth, we kind of just put it in there and it like hangs off of their face. And we're just like, oh, see, that looks good. But the biggest trick to it is that when you put it in their mouth, you seat it all the way down. Don't wait for them to bite. Seat it for them, because if they feel what it's going to feel like it won't feel any worse than when you seat it. Like you'll put it all the way down, push it down to the mandible or the occlusal surface of the mandibular teeth, and you seat it all the way down and then have them bite, it'll essentially feel the same. But if you kind of float it in there and it's just hanging in the midst, and then they have to close to push it down, they'll never want to push it down. So that's the biggest trick, is like seat it fully for them first, and practice that with Dexter. Be like, this is where I want to do, and then have Dexter bite, instead of like having the closing of Dexter push it down. And I know sometimes Dexter's tongue is a nightmare, but try, the best you can practice it. But that's what happens very oftentimes. Patients don't bite down. We don't seat it fully enough. Yeah. There are some images. Yes, there are some images. And I think they all are around errors and placement. Placement is one of the errors. So yeah, there are some images, and you'll have to pick them. Yeah.
Sometimes the patient just move it,
Yes. Yes, and that can happen. Like they can open and it might fall, and so you ran out to push the button, but they took it out, or they opened their mouth or something, and then you just have to redo it, and you have to say, you have to nicely encourage them to hold still and keep biting, because the more that happens, the longer it takes. So there's some ways to kind of work through it with the patient. And then of course, if you're really having trouble, your instructor will come and help you. And if it's and this is the rare case, so don't have this be like your go-to, but if it's like an incredibly difficult patient, sometimes we have to just do a pano and call it good, bite wings and a pano, but that is never like what we want to do. That's like the last resort. But that does happen sometimes. Cutting off, a lot of times what you'll do more than cut off the incisal edge is you'll cut off, you'll get not enough bone around the apices. But this just has to do with placement. The biggest reason this happens is if you go to use the stickies instead of your XEPs. We have the stickies because they are a little bit easier for patients to tolerate, but if you don't put it in the right area, you'll cut off the incisal edge. You have to put it in the right area so when they bite, it covers enough of the tooth. And some of the instructors hate those stickies, so it's literally like a last resort, but sometimes you have to use them because they're smaller and the patient just can't tolerate the XEPs that we have. But this is usually what happens when you use the sticky ones for the posterior or the anterior PAs. Technique area, a placement error can be any of the following: missing crowns, missing apices, not far enough forward, not far enough back. Shade the area of the box that indicates the direction the film should be placed in order to correct the image. And you guys are doing great with that already. So with the beam centering, where would my beam go to correct the beam centering error? For placement, which direction do I move the film to correct the placement error? You guys are doing really good with that. So there's this, just, you guys already know this. Do you have any questions with this form, or is everyone feeling pretty comfortable with this form? Like, I'm not comfortable.
So, just if you don't mind going over again, which ones are the ones you put direction?
Yes. Yep. So of the four, the horizontal, angulation, and vertical are just an X. So you just mark it, it's there or not there. Placement, you're going to do your X, and then you'll shade the direction that you want to move your sensor. So if you need to move anterior and maxillary or up, then shade anterior and up. And remember, and a lot of you guys did do this, you just kind of instinctually figured it out. But remember, basically right through the center is the midline. So anterior will be over here, but anterior will be over here on this side. So anterior is not the same on every box. And so like if you're moving, if you need to move for this maxillary PA, if you need to move posterior and down, or posterior and up, let's just say, you'll shade here and you'll shade here. But if the same thing happened over here, you'd shade back here and up here. So it has to mirror it. And then for beam centering error, you do your X, and then you just shade where you move your beam. And remember, you always, always, always go in the direction of the error for beam centering. So if there's a beam centering error on the bottom, you move your BID down. If it's on the anterior portion, you move it anterior. You always move in the direction of the error. And you can do an R here. You can do an R if you know it's a retake. Other can be things like patient didn't close, film tilted, you know, just different patient moved if the film's a little blurry, different things like that. Okay, so here we have, let's see, what time is it? Oh my gosh, I have 8 minutes. Okay, I don't want to skip practice, but let's skip practice because I just want to pull up the mounting really, really fast. Darn it all. The mounting lecture literally has like 8 slides, but I just want to go over it really fast. Or I guess it has 13. Okay, so this is an example of an FMX, but it has one more film than what we do. So this has sort of centering like 8 and centering 9. We just center 8 and 9. So this is a little different than ours. But the term mount can be defined as to place in an appropriate setting or for display of study in dental radiograph. Film mounting, we're mounting. Digital films do this for you. You guys are you notice that there's a sequence, and we can talk a little bit about our preferred sequence, but you'll notice that it's already highlighting where it wants you to go. You can change that. You can say, well, I'd actually prefer to go here. So you can change it, but generally speaking, digital just mounts it for you. But we'll practice tomorrow with traditional mounting, so you guys can look at some films and actually mount them, practice mounting them, the traditional films.
I feel like sometimes like email,
Yeah. Yeah. You actually have to do it. Yeah, it definitely can still happen. There's lots of, these are all traditional film mounts. There's different types made of different things, plastic or cardboard. Again, if it's digital, usually they just print it out on photo paper. Any trained dental professional can mount a film and which that sort of sounds self-explanatory. You do want to mount a film immediately because you don't want to like mess up which one is the right and left, and usually there's ways to have taken it so that anybody who's been in dentistry long enough could figure it out, but you don't want to leave unmounted films just floating around the office if it's traditional. Mounts are used to improve the view and interpretation. Obviously, a lot of this is sort of outdated because we use digital and it's all right there. Patient's name, date of exposure, the dentist, and the name of who exposed the radiographs need to be part of it, which is already a part of it on a digital. But if you're mounting a traditional film, these are the things that have to be there. Here is again a repeat link to that activity. This is in Moodle under the activities. It's like right before week 1, but this is just another link to get to it, and you can practice mounting through this digital link, which is kind of fun. It gives you like, I think 10 different sets to mount. So I'd encourage you to do that. Mounting front to back, if it's a traditional film, and you do need to know this because you're going to be tested on mounting a traditional set of films. So there is a little dot, and you'll be able to play with this tomorrow, but there's a little raised dot on a traditional film, and that dot should always be facing out. So all the dots, you should be able to feel that little bump, and they'll face, as you're looking at your set of films, all the dots should be pointing towards you. So you should feel the little raised dot. If it's digital, it's already done for you. You don't have to worry about flipping it back and forth. Maxillary things, some things to help you recognize a maxillary film. There's 3 roots. We have the buccal or the mesial distal and the palatal root. You can see the maxillary sinus. Anterior teeth are going to be larger on the maxilla than on the mandible. For the mandibular PAs, mandibular molars just have the 2 roots, and they're usually very clear and obvious. Of course, there could be an anomaly, but in general, there's just going to be 2 roots. There's something called the curve of Spee, and when you look at 4 bite wings, it looks like a gentle smile. So you can see it sort of in your bite wing films, but you can also look at it in most people's FMXs. There should be sort of this gentle smile. And if it's some people's bites, or if they've ground their teeth down, it could be very flat, but there should never be, especially mandibular films that look like a frown. That would be highly unusual. So there's usually always this sort of gentle smile, and that's called the curve of Spee. You also can oftentimes see the external oblique ridge, which is this curve, this area right behind the second mandibular molar. So this is a key to a mandibular image only. You see this gentle curve up, get my mouse, this gentle curve up. That's the external oblique ridge. And that's going to be something you guys will be tested on in your landmark exam anyway, so good to know that. And then anterior teeth are obviously smaller than the maxillary anterior teeth. So here are some images here. So which image is this one? That's a canine shot. And is it a maxillary or mandibular canine shot? And what made you think that? Oh, you guys are so smart. And then what about this one here? What's this shot? Mandibular or maxillary? And what do you see there? 2 roots. And what else? Anything else? Oh my gosh, yes. That's the mental foramen. And this is the submandibular fossa. See how it looks a little thinner right through there? So that's the submandibular fossa. And that's another thing that you'll be tested on with the landmark. So what's going on here? Is it upside down? Yeah, it's upside down. And what makes you think that? Yeah. You can see that this kind of external oblique ridge is going down, and then you can also see the tuberosity there on the maxillary molar. And then you can see those 2 clean roots. And then what about this one? That's a bite wing. Oops. Oh, wait. Did it look like it was correct or incorrect? They're close. They're awfully closed, aren't they? But it's correct, right? Good. Yep. You can see a little bit of the ridge coming down through here. You can see there's 2 roots. there's not much of a curve of speed, but you can kind of see in general that there's other key things to kind of let you know that that's correct. And then for this one, what do we have here that stands out at us? The sinus, yeah. And then what about this one? What's going on there? Yeah, good job. What about this one here? Mandibular, yeah. And it's, yep, so this one's what? Upside down? Good. You guys are so good. Okay, let's see what else we have. So here's just some summary of the helpful hints. So we have sort of a gentle curve here that's showing that here and how this would be correct and this is incorrect. And then this is to help you with the right and left. So when you look at a set of films, you can sort of like lay that over your patient's face. So it's like your left is their right and vice versa when you're looking at a set of films. And then this is also showing you how in a traditional film, there's a little dot and it's going to be facing towards you. So just some little helpful hints for mounting. I don't know if all films have that, but maybe they do. That'd be good. We'll look for that tomorrow and see, because I don't remember that, but maybe they do. Yeah. Oh, it actually, that might be something I didn't ever pay attention. We'll have to look at them tomorrow, because that would be another good thing to make note of. It's on the actual film. It just says A.
In the mouth.
Yeah. Oh, before you develop it, it's on the outside of the package?
Yeah.
Oh, okay, yeah, I don't know. I'll have to look. That's good. I always learned dot in the slot. So it was like, I never really looked for anything on the outside of the package other than where the dot was.
Like it was like Instagram and
Then you knew you had to. Oh, I'll have to look at that. Yeah, I'm not familiar with that. That's cool though. Let me see. And then just a couple more landmarks that are in the mouth and then sequencing. Oh, sorry, I went over.